Welcome. Thank you for joining us for today's Take Action Group, which is a partner program of our organization, the Epilepsy Foundation of Greater Los Angeles, and the Epilepsy Center of Excellence at the West Los Angeles VA Medical Center. Today we have Dr. Joanna Gann, a Neurobehavior and Neurophysiology Fellow with the West Los Angeles VA Medical Center, joining us today to talk about causes, risks, and other comorbidities. With that, Dr. Gann, would you like to introduce yourself and begin?
Thanks, Rebecca, for the introduction. My name's Joanna Gann. I currently work at the VA facility in West Los Angeles, and I am training in both epilepsy, which are seizures, and behavior, which is other aspects of neurology that overlaps to a certain extent with psychology as well. So I'm particularly interested in the intersection of epilepsy and behavior, and what that means is not only focusing on epilepsy, but also the comorbidities, what we call, the other psychiatric aspects that affect daily life for an individual with epilepsy. Can we move on to the next slide? Okay, so this is just a cartoon, and I figure I'd keep it light, and this is actually a cartoon trying to depict someone having a seizure, but I want you to pay attention here because they're pretty much doing everything the wrong way in this cartoon. So essentially, when you see someone having a seizure and they're shaking, you don't want to restrain them the way that this boy is being restrained. Typically, you would just want to roll them onto the side and let the seizure run its course. Don't put anything in the mouth. Don't try to hold the person down. Okay, next slide. So this is a simplified version of what the brain does. This is important, I think, even though my talk isn't focused on brain anatomy, that it's important to understand what epilepsy is, and I'm starting here. As you noticed, on the left side is the front of the brain, on the right side of the picture is the back of the brain, and you're looking at the brain from the side. And you notice that there are different colors and for different parts, and pretty much the brain is divided into a few lobes that are labeled here, and you can see that different things happen in different parts. And that's important to keep in mind because when a seizure occurs in the brain, it affects one or more of these parts. Next slide. Okay, so a little bit about seizures in general. They are caused by what we call an abnormal electrical impulse that runs through the brain. So our brain communicates normally through electricity, but there are some individuals, sometimes we know the reason, sometimes we don't, who have brains that are more likely to have kind of what we call a synchronized electrical activity. And some of the causes listed here are the ones that we know of, and they're the most common causes. Genetic is the probably most common cause. In the medical community, we so far are working on figuring out the various types of genetic mutations and makeups that cause someone to be more prone to having seizures than others. Trauma to the brain, this is very common, especially in the veterans population. Essentially, the part of the brain that's damaged is the part that usually later on may or may not develop into an area that is prone to having seizures. Other things that are common in general, strokes in the slightly older population, brain tumors, of course, and then any kind of brain infection as well. Next slide. And just kind of tagging along with the genetic aspect of things. So oftentimes in an individual that have seizures, you may find that the rest of the family has a tendency to. So perhaps the person will have a mother or a father or a sibling or a cousin, a grandparent who has seizures as well. Next slide. This is a picture of an EEG. This is something I just want everyone to understand what doctors are talking about when they talk about EEGs. This is a recording using electrodes on the brain so that we can see what electrical activity is going on at the time the recording's happening. So to basically explain this picture here, the parts of the line that look relatively flat are the areas that are more normal, and then you'll see towards the right bottom part of this graph here where the lines look kind of jagged and they look kind of like they're going on. There's a little rhythm happening, and that is a portion where this person is experiencing a seizure. So I just wanted you to know what we mean and what we're talking about when you look at an EEG. Okay, so that's pretty much the portion on seizures, and I'm going to start moving on to what I was commenting on, the kind of other aspects of epilepsy and having so-called a seizure disorder and the often unaddressed aspects of it. So I would like to start by just making the connection between the mind and the body. And this is, I think, very important because a lot of people and even some physicians forget that the way our body reacts is directly related to our nervous system. In this picture, you see here that the top portion that looks like a helmet on the left side is the brain, and the long, string-like extension that's coming out of it is your spinal cord, and all the different lines that you're seeing, the red, the green, are nerves that are coming from essentially your brain and going to different parts of your body. And so, for example, the very top part, you see there's an eyeball there, and that's to signify that, for example, if you are scared or surprised, typically your nervous system will send an impulse through that nerve and tell your eyes to dilate. So your pupils will dilate in that situation. And these are things that happen naturally. Take a look at the image of the heart there. So when again, if you're being pursued by in a dangerous situation, your brain sends an impulse telling your heart rate to speed up, and you feel like your heart's pounding. So there's a direct connection between what I'm trying to say is your particular situation, your emotions, and what your body does. So next slide. And more cartoons here. This is just a cartoon depicting a man who is scared. And what we notice here is some of the physical reactions of what I just discussed in the prior slide. He's kind of shaky, and also his hair is standing up, and his eyes are wide open, and he looks quite frightened. And these are responses our body has to stress. Next slide. And I'm going to jump into a topic that is very common in patients with epilepsy that is not discussed enough, in my opinion. So this tends to occur anywhere from 20 to 30% of people with seizures, and it is known at the current in the community as psychogenic nonepileptic seizures. You may have heard about this as pseudo-seizures. You may have heard of this as a functional neurologic disorder. Regardless of the name, what this condition represents is usually some kind of event that the individual experiences that mimics a seizure, but it does not come with the electrical abnormalities in your brain. So if you think back to a few slides earlier when I showed you that EEG, that graph with the seizure happening, essentially in psychogenic nonepileptic seizures, your body looks like it's having a seizure, but your brain's actually not. And in recent years, there have been more discussion about this topic, which was previously rather unknown. It's an expression of psychological distress through physical symptoms. There's actually a word to describe this. It's called somatization, and it's not. It's a word that describes many types of ways where your body can represent psychological stress. So in this particular situation, the person is experiencing an episode that looks like seizures, but it's really not the same type of seizures. Other examples of this happening is much milder versions. For example, as I was starting to mention earlier, when you are scared, you may feel like all the hairs on your body is standing up. Maybe you'll feel like that you're sweating uncontrollably. A lot of veterans with experiences in the military that were traumatic for them will often will experience kind of flashbacks, and during these events they can tell that their body is quite uncomfortable. As I mentioned, this happens to a good proportion of patients with seizures, and I want to make it clear that this is different from epileptic seizures, but you can have both at the same time. And this condition also is correlated with depression, anxiety, and I don't have it listed here, but also PTSD. There are some in our community who actually think that psychogenic non-epileptic seizures is a type of PTSD. Next slide. Can we go one more? Okay. I put this slide up because I think why do I mention psychogenic non-epileptic seizures here? The reason being psychogenic non-epileptic seizures and epileptic seizures have different causes. One is electrical abnormalities. The other is actually past traumatic experiences and the body acting on them in an abnormal and maladaptive way. So it's important to distinguish them so that we can treat them properly. Epileptic seizures you can treat with anti-seizure medications, and they tend to help reduce the frequency of seizures or reduce the severity of the seizure itself. However, non-epileptic seizures are not treated with anti-epileptic medications. In fact, they don't work at all, and in some situations actually make it worse because all medications come with side effects, and essentially that person is taking a medication that doesn't work but experiencing the side effects at the same time. And particularly in the veterans population, from having worked here for 2 years, I am it's an extremely gratifying place to be for me professionally, because I'm working with individuals who have served our country, and now, essentially I feel like I have the opportunity to serve those who have served us. However, this is also a population that I have noticed of very stoic men who are not used to being told that, hey, experiencing emotions isn't okay. It's part of life. And I think that is a detriment to those who experience epilepsy, because depression, anxiety, PTSD, non-epileptic seizures, all these conditions, comorbidities, are extremely common in individuals with epilepsy. I want to say up to 30% for depression, 20-30% for anxiety, etc. So it's something that I highly, highly encourage that you talk to your doctors about. Being depressed is not a sign of weakness. It can be treated, and it should be. The longer you go untreated, the harder it is to do so. Next slide. Okay, I'm just going to switch gears a little bit and talk a little bit about what concerns everyone, especially in California, where driving is an essential part of life. So doctors in California and in many other states are mandated to report any person that if they suffer from any kind of condition that causes a loss of consciousness. And these include seizures, and that's the most common type, but it also includes syncope, which is fainting, spells, and also narcolepsy, which is when an individual falls asleep when they don't want to, under, in situations where it could be dangerous. And this is difficult for everyone involved. The reason why we have to do this, as you know, as a doctor myself, is that we want to make sure that our patient is safe. We want to make sure that other people on the road is safe. And you know, imagine if you're losing consciousness while you were driving. You have no control of the vehicle, and you know, unfortunately, I have seen patients who have passed away from car accidents because they experienced a seizure while they were driving. Okay, next slide. Okay, this is just a quick copy of the form that we're required to submit. It's I don't want to feel like, you know, we're doing anything. Whenever I submit one of these forms, I tell my patients directly, you know, I have to do this by law, and don't be surprised when you may receive a letter in the mail. So what I'm doing is I'm reporting the situation to the Department of Public Health, who then handles the rest. And that part I'm not involved with. So next slide. All right, I figured that this is probably important for those who are affected by the inability to drive, so I'll comment a little bit about, well, how can you get back to driving again? So what happens when a physician or a healthcare provider submits one of those forms is that, generally speaking, you'll be put on either one or two, or, you know, a probation of some sort. That I'm not exactly sure what happened to type 1, by the way, because there's only type 2 and type 3 here. But anyhow, type 2 is the type where you will most likely be put on in the very beginning when you're first diagnosed with a seizure or when you first start treatment for a seizure. So what this is saying is you're placed on the probation until 3 to 5 months where you're taking a medication for the seizures and you're not experiencing any more seizures. Then you go back to your doctor and say, hey, you know, I'm doing pretty okay here. Can you switch me over to probation type 3? And the type 3 is basically by the time you hit 6 months of no seizures, but the doctor still thinks, well, maybe you still have a risk for further seizures, so I don't want to completely stop monitoring you, and I would still like to see you in clinic. However, we're going to now work towards getting your license back. So the general rule is if you take your medications regularly, you don't experience a seizure, and within 6 months, so by 6 months of seizure freedom, no seizures for 6 months, that's the time where we can start working to get you your license back. Next slide. Okay, so this is essentially just going to summarize a little bit. Epilepsy and its common comorbidities can all be treated. I don't think I've emphasized that yet. So epilepsy, non-epileptic seizures, depression, anxiety, PTSD, these are all things that can be treated. And so please don't assume that by seeking help that it's a sign of weakness, because it is not. And know that you're not alone in this, you know, in dealing with this. Seizures in the general public happen to 1%. So 1 out of every 100 persons will have epilepsy. And in those who suffer from brain injuries, it is much, much higher. And also understand that for most people, driving, not being able to drive is a temporary thing. You know, help your doctor help you get your license back by taking the medications religiously and following up regularly. And that concludes my talk. There are some more slides that follow that elaborate on what I have mentioned, but in much greater detail. There's also other phone numbers provided for you, which can be of assistance to you as well, both within the veterans community and also in the Epilepsy Foundation.